Good morning, everybody. Today we will talk about hypertensive disorders in pregnancy. Every minute in the world, there are 199 unplanned pregnancy, 110 maternal outcomes, 380 women fertilized, 40 unsafety abortion, and only 39 safety delivery and 1 woman die. Hypertensive disorders during pregnancy is classified by International Classification Disease 10. Pre-existing hypertension complicating pregnancy, childbirth, and the puerperum is coding by O10. Pre-existing hypertension with proteinuria, O11. Gestational edema and proteinuria without hypertension is called O12. Gestational hypertension without significant proteinuria, O13. Preeclampsia, O14. Eclampsia, O15. And unspecific maternal hypertension is called O16. Hypertensive disorders during pregnancy. Pre-existing hypertension is known hypertension before pregnancy or raised blood pressure before 20 weeks gestation. It may be essential hypertension or less commonly secondary to underlying disease. Pregnancy-induced hypertension without significant proteinuria, O13. Gestational hypertension, the new onset of hypertension occurs after 20 weeks gestation in a woman who had normal blood pressure before 20 weeks gestation, and diastolic blood pressure is more than 80 millimeters of mercury, or systolic blood pressure more than 140 millimeters of mercury. The woman has none of abnormalities that define preeclampsia. Her blood pressure returns to normal within 3 months after childbirth. Preeclampsia, the new onset of hypertension, occurs after 20 weeks gestation in a woman who had normal blood pressure before 20 weeks, or superimposed on pre-existing hypertension, and one or more of the following also develop as new condition. First, proteinuria, spot urine protein, creatinine ratio more than 30 milligrams per millimole, or 2 plus on dipstick testing confirmed by protein creatinine ratio test. Second, renal insufficiency, creatinine more than 90 millimole per liter, urine output of less than 80 milliliters per 4 hours, liver involvement, elevated transaminase ALT and AST at least twice upper than normal level, plus or right upper quadrant of or epigastric abdominal pain, neurological complications, eclampsia, altered mental status, blindness, stroke, or more commonly hyperplasia when accompanied by clonus, severe headaches, and persistent visual scotoma. Hemolytical complications include thrombocytopenia, platelet count below than 100 on 10 above 9 per liter, and hemolysis. Severe hypertension with diastolic blood pressure more than 110 millimeters per mercury, or systolic blood pressure more than 160 millimeters per mercury, worsening the thrombocytopenia, platelet count less than 100 on 10 above 9 per liter, impaired liver function, not responding to treatment and not accounted by alternative diagnosis, elevated transaminase, and at least twice upper limit of normal, and or right upper quadrant of epigastric abdominal pain might be referred to upper back, progressive renal insufficiency, serum creatinine more than a 90 per millimole per liter, or doubling of serum creatinine concentration in the absence of other renal disease, urine output less than 80 milliliters per 4 hours, pulmonary edema, new onset of headaches and visual disturbances, HELP syndrome, and at last eclampsia. HELP syndrome is a variant of severe preeclampsia. Um, Elements include hemolysis, E, elevated liver enzymes, and L, low, and P, platelet count. In a woman with preeclampsia, the presence of any of the following is an indicator of HELP. Maternal platelet count of less than 100 to 10 above 9 per liter, elevated transaminase more than twice, usually is more than even tens. You should know also. Microangiopathic hemolytic anemia with red cell fragments on blood film. Risk factors. Advise pregnant women with more than one moderate risk factor for preeclampsia to take 75 up to 150 milligrams of aspirin daily from 12 weeks until the birth of the baby. Factors indicating moderate risk are: first, pregnancy, age more than 40 years, pregnancy interval or more than 10 years, body mass index more than 35 kilograms per meter above second or more at first visit, family history of preeclampsia and multifetal pregnancy. Prevention of preeclampsia. Aspirin in small doses, about 75 milligrams per day, and the effect is higher provided if treatment has begun between 12th and 16th weeks in pregnancy, or when taken in the evening before bedtime with continuous use from 12 to 37 weeks of pregnancy. Calcium supplementation recommend for women with high risk of preeclampsia offer calcium supplementation along with diary advice to achieve 1 gram elemental intake per day from booking to the birth. How is blood pressure measured? It is important to measure blood pressure more than once because it fluctuated over the course of the day. It can also change due to things like physical exertion, stress, pain, or extreme head or cold. But this kind of increase in blood pressure is only temporary, and it soon returns to normal. So, if blood pressure is measured just once and found to be high, it doesn't necessarily mean that it's always too high. Blood pressure reading taking at the doctor's office can also be misleading. Going to the doctor makes some people so nervous that their blood pressure goes up, so get reliable readings. Blood pressure is measured on several different days and while you are resting. This means sitting down and relaxing on the chair and waiting about 3 minutes before taking the measurement so that your circulatory system becomes to rest. The upper arm, as is being used for the measurement, should rest on a table at about the same height as the heart while the reading is being done. Assessment of proteinuria in hypertensive disorders of pregnancy. Follow proteinuria measurement for pregnant women in the context of the full clinical review of symptoms, signs, and other investigations for preeclampsia. Use the automated region strip reading device for dipstick screening for proteinuria in pregnant women in secondary care setting. If dipstick screening is positive +1 or more, use albumin, creatinine ratio, or protein creatinine ratio to quantify proteinuria in pregnant women. Do not use first morning urine void to quantify proteinuria in pregnant women. Do not routinely use 24 hours urine collection to quantify proteinuria in pregnant women. If using protein creatinine ratio to quantify proteinuria in pregnant women, use 30 milligrams per millimole as a threshold for significant proteinuria. If the result is 30 milligrams per millimole or above, and there is still uncertainty about the diagnosis of preeclampsia, consider resting on a new sample alongside clinical review. If using albumin creatinine ratio as an alternative to protein creatinine ratio to diagnose preeclampsia in pregnant women with hypertension, and use 8 milligrams per millimole as a diagnostic threshold. If the result is 8 milligrams per millimole or above, and there is still uncertainty about the diagnosis of preeclampsia, consider re-resting on a new sample alongside clinical review. Anti-Hypertensives Recommendations. Urgently treat all women with severe hypertension, diastolic blood pressure more than 110 or systolic blood pressure more than 160 millimeters per mercury of mercury with antihypertensive to acutely low blood pressure. Consider antihypertensives for women with gestational hypertension, diastolic blood pressure more than 80 or systolic blood pressure more than 140 millimeters of mercury, especially those with risk factors and or comorbidities, as well as taking account of the evidence and clinical experience. Consider the choice of antihypertensive drug in the context of resource availability, the local healthcare setting, and the condition of the individual woman. Emphasize educating women so that they clearly understand the importance of taking their antihypertensive drugs as prescribed, the symptoms of HTP, and woman and when there's report symptoms. First line antihypertensive use to treat HTP include labetalol, nifedipine, and metildopa. Nifedipine is used on 10 milligrams conventional release tablet oral. Onset of action 30 up to 45 minutes. Onset of maximum effect 30 minutes. Repeat after 30 up to 45 minutes if needed. Maximum 80 milligrams daily. Labetalol. Initially 20 milligrams intravenously, bolus over the 2 minutes. Onset of action 5 minutes. Onset of maximum effect 10 up to 15 minutes. Repeat with 40 up to 80 milligrams. Repeat every 10 minutes if needed. Maximum is 300 milligrams. Maximum 30 milligrams. Consider intravenous bolus of crystalloid fluid before or when administering first intravenous heterolysine dose, usually 200 up to 300 milliliters. Hydrolysine 5 or 10 milligrams intravenously bolus over the 10 minutes, 5 milligrams if fetal compromise, onset the action 20 minutes, onset of maximum effect 10 up to 80 minutes. Repeat every 20 minutes if needed. Management of chronic hypertension in pregnancy. All women with chronic hypertension referral to a specialist in hypertensive disorders of pregnancy to discuss the risk and benefits of treatment. Advise women who take angiotensin converting enzyme ACE inhibitors or angiotensin II receptor blockers ARBs that there is an increased risk of congenital abnormalities if their drugs are taken during pregnancy. Discuss alternative antihypertensive treatment with the healthcare professional responsible for managing their hypertension if they are planning pregnancy. Discuss alternative treatment with the healthcare professional responsible for managing their condition, or angiotensin converting enzyme inhibitors or angiotensin II receptor blockers are being taken for other conditions such as a renal disease. Stop antihypertensive treatment if women taking angiotensin converting enzyme inhibitors or angiotensin II receptor blockers if they become pregnant, preferably within 2 working days of notification of pregnancy, and offer alternatives. Advise women who take thiazide or thiazide-like diuretics that the way may be increased risk of congenital abnormalities and neonatal complications if these drugs are taken during pregnancy. Discuss alternative antihypertensive treatment with a healthcare professional responsible for managing their hypertension if they are planning pregnancy. And advise women who take antihypertensive treatment other than angiotensin converting enzyme inhibitors or angiotensin II receptor blockers, thiazide or thiazide-like diuretics, that the limited evidence available has not shown an increased risk of congenital malformation with such treatment. Treatment of chronic hypertension. Offer pregnant women with chronic hypertension advice on first, weight management, second, exercise, third, healthy eating, fourth, lowering the amount of salt of their diet. Continue with existing antihypertensive treatment and if safe in pregnancy, or switch to an alternative treatment unless first, sustained systolic blood pressure less than 110 milligrams of mercury, or sustained diastolic blood pressure less than 70 milligrams of mercury, or the woman has a systematic hypertension. Offer antihypertensive treatment to pregnant women who have chronic hypertension and who are not already on treatment if they have sustained systolic blood pressure of 140 milligrams of mercury or higher, or sustained diastolic pressure of 80 milliliters of mercury or higher. When using medicine to treat hypertension in pregnancy, aim for a target blood pressure of 135 per 85 millimeters of mercury. Consider labetalol to treat chronic hypertension in pregnant women. Consider nifedipine for women if labetalol is not suitable, or methyldopa if both labetalol and nifedipine are not effective. Base the choice on any pre-existing treatment, side effects, profiles, risk, including fetal effects, and woman's preference. And offer pregnant women with chronic hypertension aspirin 75 up to 150 milligrams once daily from 12 weeks. Antenatal appointment. In women with chronic hypertension, schedule additional antenatal appointments based on the individual needs of the woman and her baby. These may include weekly appointments if hypertension is poorly controlled, appointment every 2 up to 4 weeks of hypertension is well controlled, management of gestational hypertension, assessment and treatment of gestational hypertension. On women with gestational hypertension, a full assessment should be carried out in a secondary care setting by a healthcare professional who is trained in the management of hypertensive disorders of pregnancy. On women with gestational hypertension take account of the following risk factors that require additional assessment and follow-up: nulliparity, age 40 years and older, pregnancy interval more than 10 years, family history of preeclampsia, multifetal pregnancy, body mass index more than 35 kg per meter above second or more, gestational age and presentation, previous history of preeclampsia or gestational hypertension, pre-existing vascular disease, and pre-existing kidney disease. In this table, I presented the management of pregnancy with gestational hypertension, which depends on degree of hypertension. If degree of hypertension, blood pressure of 140 on 90 up to 160 on 110 millimeters of mercury, it is not routinely to admit a hospital. Offer pharmacological treatment of blood pressure remains above 140 to 90 millimeters of mercury. Aimed for blood pressure of 135 to 85 millimeters of mercury or less, once or twice a day depending on blood pressure. You should measure blood pressure until blood pressure is lower than 135 to 85 millimeters of mercury. Dipstick proteinuria testing is used for once or twice a week with blood pressure measurement, and measure full blood count, liver function, and renal function during the examination, and then weekly. Offer fetal heart auscultation at every antenatal appointment. Carry out ultrasound assessment of the fetus. If it normal, repeat every 2 or 4 weeks. If clinically indicated, and carry out a CTG only if clinically indicated. And if blood pressure of 160 to 110 millimeters of mercury and more, you should admit. But if blood pressure falls below 160 to 110 millimeters, then manage as for hypertension. Offer pharmacological treatment to all women. Aim for blood pressure is less than 135 to 85 millimeters of mercury. Every 15 and 30 minutes until blood pressure is less than 160 to 110 millimeters of mercury, blood pressure should be measured. Daily dipstick proteinuria testing is used. Measure food blood count, liver function, and renal function during the examination and then weekly. Offer fetal auscultation at every antenatal appointment. Carry out ultrasound assessment of the fetus if it's normal. Repeat every 2 weeks if severe hypertension persists. And carry out of CTG diagnosis, and then only if clinically indicated. Timing of birth. Do not offer planned early birth before 37 weeks to women with gestational hypertension whose blood pressure is lower than 160 to 110 millimeters of mercury, unless there are other medical indications. For women with gestational hypertension whose blood pressure is lower than 160 to 110 millimeters of mercury after 37 weeks, timing of the birth and maternal and the fetal indication for birth should be agreed between the woman and the senior obstetrician. If planned early birth is necessary, offer the course of antenatal corticosteroids and magnesium sulfate. Postnatal investigation, monitoring, and treatment. In the woman with gestational hypertension who who have given birth, measure blood pressure daily for the first 2 days after birth, at least once between 3 and 5 days after birth, as clinically indicated if anti-hypertensive treatment is changed after birth. In women with gestational hypertension who have given birth, continue anti-hypertensive treatment if required. Advise women that the duration of their postnatal anti-hypertensive treatment will usually be similar to the duration of their antenatal treatment. Reduce anti-hypertensive treatment if their blood pressure falls below 130 to 80 millimeters of mercury. If a woman has taken methyl dopa to treat gestational hypertension, stop within 2 days after the birth and change to alternative treatment if necessary. For women with gestational hypertension who did not take antihypertensive treatment and given birth, start antihypertensive treatment if their blood pressure more than 150 to 100 millimeters of mercury or higher. Write a care plan for women with gestational hypertension who have given birth and they are being transferred to community care that includes all of the following: who will provide follow-up care, including medical review if needed, frequency of blood pressure monitoring needed, threshold for reducing or stopping treatment, indications for referral or primary care for blood pressure review. Or for women who have had this gestational hypertension and who remain on antihypertensive treatment, a medical review with their gestational hypertension or specially of their GP or specialist 2 weeks after transfer to community care. Overall, women who has gestational hypertension, a medical review with their GP or specialist 6 up to 8 weeks after the birth. Management of preeclampsia. Assessing preeclampsia, carry out a full clinical assessment at each antenatal appointment for women with preeclampsia and offer admission to hospital for surveillance and any interventions needed if there are concerns on the well-being of the woman or baby. Concerns could include of the following. First, sustained systolic blood pressure of 160 millimeters of mercury or higher. Any maternal biochemical or hematological investigation that cause concern, for example, new and persistent. Rise of creatinine, 90 micromole per liter or more, or 1 gram per 100 milliliter or more, or rise in alanine transaminase over the 70 per liter, or twice upper limit of normal range, or falling platelet count under 150,000 per microliter, sign of an impending eclampsia, sign of impending pulmonary edema, other signs of severe preeclampsia, suspected fetal compromise, any other clinical signs that cause concern. Management of pregnancy with preeclampsia. Uh, Here you can see if the blood pressure is less than 160 to 110 millimeters of mercury, offer pharmacological treatment if blood pressure remains above 140 per 90 millimeters of mercury. Aim of blood pressure is less than 135 to 85 millimeters of mercury. Blood pressure uh, you should measure at least every 48 hours and more frequently if the woman is admitted to hospital. Uh, deep deep stick proteinuria testing is repeated only if clinically indicated. For example, a new symptom and sign develops if there is uncertainty over diagnosis. Measure full blood count, liver function, and renal function twice a week. Offer fetal heart auscultation at every antenatal appointment. Carry out ultrasound assessment of the fetus at diagnosis and, if normal, repeat every 2 weeks. Carry out of ECG at diagnosis and then only if clinically indicated. Severe hypertension means blood pressure more than 160 to 110 millimeters of mercury and more. Pharmacological antihypertensive treatment should be to all women. Aim of blood pressure is less than 135 to 85 millimeters of mercury or less. Every 15 or 30 minutes until blood pressure measured by every 30 minutes until blood pressure less than 160 to 110 millimeters of mercury, then at least 4 times daily while the woman is inpatient, depending on clinical circumstances. Only repeat if clinically dipstick proteinuria testing is repeated only if clinically indicated. For example, if new symptoms and signs develop or if there is uncertainty over diagnosis. Blood test should be measured. Blood test, liver function, blood count, renal function 3 times a week should be measured. And offer fetal heart auscultation at every antenatal appointment. Carry out ultrasound assessment of the fetus at diagnosis and, if normal, repeated every 2 weeks. Carry out a CSTG as a diagnosis and then only if clinically indicated. Timing of birth in women with preeclampsia before 34 weeks. Continue surveillance unless there are indications for planned early birth. Offer intravenous magnesium sulfate and the course of antenatal corticosteroids. From 34 up to 36.6 weeks, continue surveillance unless the indication for planned early birth. When considering the option of planned early birth, take into account the women's and baby's conditions, risk factors such as a maternal comorbidity, multi-fetal pregnancy, and availability of neonatal unit beds. 37 weeks onwards, Initiate birth within 24-48 hours. Postnatal investigation, monitoring and treatment, including after discharge from critical care. Blood pressure. In women with preeclampsia who did not take antihypertensive treatment and have given birth, measure blood pressure at least 4 times a day while the woman is an inpatient, at least once between day 3 and day 5 after birth, on alternate days until normal if blood pressure is abnormal, on days up to 5. In women with preeclampsia who did not take antihypertensive treatment and have given birth, start antihypertensive treatment if blood pressure is more than 150 to 100 millimeters of mercury or higher. In women with preeclampsia who took antihypertensive treatment and have given birth, measure blood pressure at least 4 times a day while the women are inpatient. Every 1-2 days for up 2 weeks after transfer to community care until the woman is off treatment and has no hypertension. For women with preeclampsia who have taken antihypertensive treatment and have given birth, continue antihypertensive treatment. Consider reducing antihypertensive treatment of their blood pressure falls below 140 to 100 to 90 millimeters of mercury. Reduce antihypertensive treatment if their blood pressure falls below 130 millimeters to 80 millimeters of mercury. If a woman has taken methyl-dopa to treat preeclampsia, stop within 2 days after the birth and change to alternative treatment if necessary. For women with preeclampsia who have given birth, transfer to community care if all of the following criteria has been met. There are no symptoms of preeclampsia. Blood pressure of or without treatment is less than 150 to 100 millimeters of mercury. Blood test results are stable or improving. While a care plan for women with a preeclampsia who have given birth and they are being transferred to community care that include all of the following. Who will provide follow-up care, including medical review if needed. Frequently of blood pressure monitoring. Thresholds for reducing or stopping treatment. Indications to referral to primary care for blood pressure review. Safe self-monitoring for symptoms. Of women who have had the preeclampsia and who remain on antihypertensive treatment, a medical review with their GP or specialist 2 weeks after transfer to community care. Offer all women who have had preeclampsia a medical review with their GP or specialist after 6 or 8 weeks after birth. Hematological or biochemical monitoring. In women who have preeclampsia with mild or moderate hypertension or after step down from critical care, measure platelet count, transaminases, and serum creatinine after 48 to up to 72 hours after the birth or step down. Do not repeat platelet count, transaminase, or serum creatinine measurements if results are normal at 48 up to 72 hours. If biochemical and hematological indices are outside the reference range in women with preeclampsia who have given birth, repeat platelet count, transaminase, and serum creatinine measurements as clinically indicated until results return to normal. In women with preeclampsia who have given birth carry out an urinary region strip test after after 6 up to 8 weeks after birth. Of women who had preeclampsia and still have proteinuria 1 plus and more at 8 up to 8 weeks after the birth, and further review with their GP or specialist at 3 months after the birth to assess kidney function. Consider referring women with abnormal kidney function assessment at 3 months for specialist on chronic kidney disease in adults. Medical management of severe hypertension, severe preeclampsia, or eclampsia in critical care setting. Anticonvulsants. If a woman in a critical care setting who had severe hypertension or severe preeclampsia has previously had an eclamptic fit, give intravenous magnesium sulfate. Consider giving intravenous magnesium sulfate to women with severe preeclampsia who are critical care setting and birth is planned within 24 hours. Consider the need for magnesium sulfate treatment if one or more of the following features of severe preeclampsia is present. Ongoing or recurring severe headaches, visual scotomata, nausea or vomiting, epigastric pain, oliguria, and severe hypertension, progressive deterioration in laboratory blood tests. Use the collaborative eclampsia trial regimen for administration of magnesium sulfate. A loading dose of 4 grams should be given intravenous over the 5 to 15 minutes, followed by infusion 1 gram per hour maintained for 24 hours. If the woman has had an eclamptic fit, the infusion should be continued for 24 hours after the last fit. Recurrent fit should be treated with a further dose of 2 up to 4 grams given intravenously over the 5 to 15 minutes. Anticonvulsants. Do not use diazepam, phenytoin, or other anticonvulsants. As an alternative to magnesium sulfate is women with eclampsia. Anti-hypertensives. Treat women with severe hypertension who are in critical care during pregnancy or after birth immediately with one and the following: labetalol, oral or intravenous, oral nifedipine, intravenous hydralazine. In women with severe hypertension who are critical care, monitor their response to treatment to ensure that their blood pressure falls, to identify adverse effects for both the woman and the baby, to modify treatment according to response. Consider using up to 500 milliliters crystalloid fluid before or the same time at the first dose of intravenous hydralazine in the antenatal period. Here is a clinical criteria for choice of critical care level. First level means preeclampsia with hypertension, ongoing conservative antenatal management of severe preterm hypertension, step-down treatment after the birth. Level second care, step down from level 3 or severe preeclampsia with any of the following complications: eclampsia, HELP syndrome, hemorrhage, hyperkalemia, kalemia, severe oliguria, coagulation support, intravenous antihypertensive treatment, initial stabilization of severe hypertension, evidence of cardiac failure, abnormal neurology, and the severe preeclampsia is level 3rd care, which is needed by ventilation of lungs. Thank you for your attention.